Patients made complaints, but because there was the NHS contract was not used, Castlebeck's own contract was used, there was no annual account of complaints. And I fear that even if there had been, complaints wouldn't have been attended to. Nobody asked patients why they were distressed, or nobody attributed their self-injurious behaviour to the fact that they were desperately unhappy. Some people were in pain, many were traumatised, many had communication difficulties. And this was a failing hospital. Those are signs of a failing hospital, it would seem to me. We've also learned that challenges in helping distressed people and their families don't go away by sending people away from all that's familiar. And the scandal of Winterbourne View Hospital exposes the fiction that hospitals and assessment and treatment units for adults with learning disabilities and autism solve problems. They don't. The current system, as glimpsed by this place, appears to have arisen from very poor NHS commissioning. No questions asked, here's the cheque, and no reliable account of what that service was authentically delivering. Many families showed me accounts of the assessments arising from their daughters' and sons' placements. And one family said, how long does it take to assess someone? How long does it take to assess someone? Because he's been there for 2 years, and look at this crap on paper. And indeed, it concluded a lot of imported material, even changing the gender occasionally of the patient. This was not a personalised service. It was not even a relationship-centred service. It was, however, a demand-led service, and primary care trusts and the health boards in Wales made spot purchases. So commissioners were not in touch with each other, and they weren't comparing notes, and they weren't asking questions either individually or collectively. There was no overall leadership, and given the growth of assessment and treatment units for adults with learning disabilities and autism since 2000, it seems that placements in these units are really the default commissioning response. It's the Friday afternoon, we haven't a clue what to do. Thank God there's an assessment and treatment unit nearby. The other lesson is that people with learning disabilities and autism who become known to mental health services and or the criminal justice system could not possibly thrive in what was an anti-therapeutic environment which developed at this hospital. I was struck by how small the place was. And in fact, we saw glimpses of the sitting area where people were corralled, and that's the verb that they use. We corral people into the sitting room and in peripheral seating. And it must have been terrifying when Wayne was on duty, because you would not want to catch his eye because his behaviour was so very threatening. I think another lesson is that, unlike NHS commissioners, the Care Quality Commission, Avon and Somerset Police, and Adult Safeguarding in South Gloucestershire, they had to rely on what they were told by Winterbourne View Hospital staff. The police took a couple of calls one evening from a patient who said, "Can you get here? It's terrible." The police rang the hospital, and a member of staff said, "It's absolutely fine." They acknowledge that had that been a child, they wouldn't have made a follow-up call. They'd have just gone. They know that they made mistakes. But there was almost a cycle of deference. This is a hospital. We have high expectations of hospitals. There are clinicians there. They know what they're doing. But all of these agencies relied on the clinicians and staff, people steeped in practice, and there was a very passive quality assurance system in place. And they relied on these people to describe scenarios where staff were alleged to have assaulted patients. Neither Adult Safeguarding nor the police were given a full picture of events at the hospital, most particularly concerning the frequency of incidents. Sometimes it was in people's nursing records, medical records, care plans, that we learned of the number of occasions that people were subject to the T-supine restraints that gets people onto the floor with staff lying across them. And it seemed to me that a failing hospital is not characterised by transparency. And a lot of safeguarding work, as you will know, relies on bringing together imperfect information, hunches, concerns, just a feeling that something's not right. It has to cross professional and organisational boundaries, and we have to maintain relationships. And it does appear that the hospital was particularly good at reassuring both the police, adult safeguarding, and assessment and treatment, accident and emergency, that things were okay. Where do we want to be? I found it really interesting that I think we've said in the report that the silencing of these patients was scandalous, but also the silencing of their families. We know that what keeps people safe is other people. We have to have policies and procedures. They're important, but actually it's other people. It's folk who say, I've known this man for X years. There is something wrong. I know there's something wrong. And to be tenacious. And there was no tenacity in the system. So although there were many professionals going into this hospital, they were unduly reassured by deference to clinical staff and support staff. And the hospital was very effective in closing off contact with people in the top ward where the worst abuses were filmed. So where we want to be is that we very much want NHS commissioning and regulatory activities to involve working with adults with learning disabilities and their families and their advocates. And that putting people in out-of-area units entails risks of patients not only receiving abusive treatment, but also being out there for an unknown time frame. I found it really troubling that not even the first-tier mental health reviewing system recommended that anybody leave this hospital. Clinical commissioning groups, the NHS Commissioning Board and authorities should be commissioning services with regard to local priorities within a geographical area, and providers shouldn't be leading the process by building hospitals without reference to local needs, and neither should the CQC then be registering them simply because they exist. That to me is a huge problem. This is a hospital that was ill-suited to regulation by standards of compliance. It was very light touch. And had NHS commissioners brought a rigorous trading standards perspective, for example, to the hospital, it's very unlikely that they would have accepted Castlebeck's contract or even continued to place adults there. The light touch regulation, light touch commissioning are incredibly ineffective approaches for closed institutions. Such institutions require registered managers. For a period of at least 2 years, there was no registered manager in place at Winterbourne View Hospital. Enforcement action should have resulted